Hey, good evening, everyone. My name is Salvatore Seely. I'm Program Director of Health and Wellness Programs here at CAMP Rehoboth. I'm so glad that you can join us this evening for such an important discussion on LGBTQ plus health topics nationally, and we are going to focus here on what's going on in Sussex County. You have a couple options this evening. You can email me, salvatore@camprehoboth.com with any questions, or else at the bottom of your screen, you can go to the Q&A and you can private me a question, and I will be able to get that to the moderator. Or in the chat option, you can also put in any questions or anything that comes up for you. And we also are live streaming this on Facebook. So if you know anyone out there, jump on your IM or your Insta and let them know that we are live streaming this event. So let's go ahead and get started. I'd like to first introduce our moderator this evening, Janet. Janet, if you want to come on up and introduce yourself, and I will let you begin to facilitate the discussion. Thank you.
Okay, thanks, Sal. Hi, everybody. I'm Janet Urdahl, and really happy to be on this presentation tonight. The folks that I'm sharing the screen with tonight are people who spend most of their time talking about the state of the healthcare of our community, and also by giving to our community in terms of making ourselves available. We're going to be looking at some of the micro issues that concern us every day in terms of being healthcare consumers in the LGBT plus community. We're also going to take a look at a macro level of what's going on federally and what may be coming down the pike for our community. So what I'm going to do is introduce our speakers, and then we'll start with the first presenter, who is going to be Michael Shankle with the National Coalition for LGBT Health Director and Health HIV Senior Director of Capacity Building. He has 24 years of experience in LGBT health, HIV prevention and care, delivery, public improvement, clinical training, technical assistance, capacity building. Michael is responsible for leading the organization's education, capacity building, technical assistance, and curriculum development efforts. He develops organizations, health departments, clinical providers, fiscal administrators, and medically underserved communities. He has also built coalitions and developed strategic public health practice partnerships at the local, state, and national level. Michael leads an opioid use and misuse learning institute for care professionals and on safe and effective opioid prescribing practices. Prior to joining the National Coalition for LGBT Health and Health HIV, Michael began his career as a research specialist with the University of Pittsburgh's Graduate School of Public Health and Department of Infectious Diseases and Microbiology. He combined experience of his behavioral health science, health research, and technology with to develop online HIV STI interventions. While there, he implemented programming that facilitated parity, inclusion, and representation of high-risk sexually active young adults in HIV community planning processes. In 2006, Michael produced and published the first public health textbook dedicated exclusively to LGBT health, entitled The Handbook of Lesbian, Gay, Bisexual, and Transgender Public Health, A Practitioner's Guide to Service. Michael joined the AIDS Action Committee of Massachusetts in 2006, first as director of the Male Center, Boston's Gay and Bisexual Men's Community Health and Wellness Center, and then as director of Gay, Lesbian, Bisexual, and Transgender Health Services. Michael has also served as chair and program chair for the American Public Health Association's LGBT Caucus Public Health Workers. And so, Sal, you're going to hate me for this, but I'm going to change the format because that's a long bio, and I want to let Michael just jump in, and then I'll go to the next bio after he's finished. So, Michael, go ahead.
Terrific. Thank you, Janet, for that. I didn't realize that we were going to be, you were going to read the whole bio, but thank you for that. So thanks, everyone, and thanks for having me tonight. I am going to, I've been asked to talk to you a little bit about the national level of health policy related to LGBTQ and how we can begin advocating for LGBTQ plus health outcomes. And what are some of the major policies that are emerging on a national level that you should keep your eye on as we move into 2021. So I want to outline some of the major LGBT health issues impacting our communities. I want to highlight health policy policy and proposed regulations that oops, I'm going to just close some of these little bitty windows here that are getting in my way. I want to highlight some health policies and proposed regulations that will have impact on LGBT health in 2021 and discuss ways to better advocate for optimal health. When we begin looking at LGBTQ plus healthcare, when we think about our heterosexual counterparts, LGBTQ plus communities desire many of the same items. They desire affordability, access, quality of care, to really be able to fully engage in healthcare services. However, there are a number of contributing factors in LGBT health that impact LGBT health outcome, such as discrimination, stigma, violence, and higher rates of other health problems. In fact, LGBT people are more likely to rate their health as poor or report more crime than heterosexual counterparts. Lesbian and bisexual women have higher rates of breast cancer. LGBT people have higher rates of HPV infection. Lesbian and bisexual women have a higher risk of cervical cancer, and LGBT and bisexual men, gay and bisexual men have higher rates of HIV and anal cancers. And LGBT individuals are more likely to be obese. They're less likely to have health insurance, less likely to fill prescriptions, more likely to use the emergency room when accessing services, and more likely to be refused healthcare services or be harassed by healthcare providers. So tonight, I'm going to talk a little bit about some LGBT policies from a health perspective and an advocacy perspective. And you're going to hear me talking a lot tonight about cost and cost savings. And both you and I both know that cost is not a single issue. However, it is a major driver, and commonly on a health policy level, on a federal policy level, is one of the major factors that drive healthcare policy discussions. So as I bring that up, you're going to hear me talking cost. But I want us to remember that we examine, and we should examine, on how it's going to impact the LGBTQ plus community. We should view this from a patient perspective, a patient protection perspective, and ultimately, how does the policy promote patient accessibility and affordability to healthcare and to medications. And so that's the kind of the lens that I use and I think about when I talk about health policy issues. On a national level, I've broken this into three parts, talking about access to healthcare, access to medications, and then talking about equal protections, the desire to access equal protections. So we're going to start with access to care. As we all know, or many of us know, the Affordable Care Act came into law in 2010, and it expanded health insurance and Medicaid to millions of Americans that could not afford and access health care. It protects us against pre-existing conditions. And oftentimes when people talk about the Affordable Care Act, or Obamacare, as some may refer to it as, we forget to include the patient protections part to the act, which protects against those pre-existing conditions, which really relates that a health company, a health insurer can, based on an HIV diagnosis, based on hypertension, a cancer diagnosis, etc. And they are not allowed to charge you a higher rate just based on having a pre-existing condition or based on sex. Women typically got charged higher rates than men because of health conditions that are specific to women. The ACA also established a requirement, 10 essential health benefits that are required for health plans in this country, and provided free preventative care for services, which I'll talk a little bit more about in a few moments, and then gave access to young adults up to 26 years of age to stay on their parents' insurance, and ultimately ended lifetime caps on healthcare services. This act has been under attack over the last 4 years in our current administration, and a lot of the advocacy perspectives that I'm talking about tonight are related to that attack on this healthcare bill, an act, and how it can be advanced in the future. One of the things that the Affordable Care Act did is protects us against those, it provides us with those essential health benefit requirements, 10 essential health benefits actually. And one of those business benefits relates to pre-exposure that some of you may be on or taking or thinking about taking. Under the Affordable Care Act, the U.S. Preventative Health Task Force provides grades for preventative services. And the U.S. Preventative Services Task Force, once they assign a grade to something, that allows or sometimes requires insurers to cover that without copay. Under pre-exposure prophylaxis, the USPS gave an A grade, which means it is substantial evidence to justify taking HIV medications to prevent HIV infection. The ACA maintains a grade A or B for preventative measures are offered without cost sharing, without a copay or coinsurance. So in January of this year, individuals will be able to access or should be able to access their pre-exposure prophylaxis medications without copay or coinsurance. This does not necessarily relate to doctor's visits and lab costs that may be associated with PrEP. So it's something that we really want to stay abreast of to make sure that insurers are in fact complying with the requirement. When we also think about access to healthcare, we also have to think about COVID-19. We've all been living for the last 9-10 months now in a COVID environment that has really ripped through America and around in our world this year. The country saw long-standing systemic health disparities intensify as people of color and vulnerable LGBT communities, many of them who work in high-risk frontline jobs and live in densely populated communities, were infected with or affected by COVID-19. For many, deeply rooted mistrust in healthcare systems has heightened, making it more challenging to engage communities on the importance of getting vaccinated against COVID-19. We have 2 vaccines that are in approval authorization right now at the FDA. We expect one to be released or given permission for emergency authorization this week. And when we think about this vaccine in our community, we really want to make sure that we build trust in our community. A lot of the information out there, widespread information out there, misinformation coupled with strong personal beliefs have pushed polling, when they did polling with vaccines, into a mistrust territory, that people mistrust it, and ultimately will undermine the pandemic if we don't at least get 80% of our population vaccinated. So we must encourage communities to engage and start having discussions around COVID-19 and vaccinations. When we talk about access to medications on a national level, there are several policies that are in place that we view as really harmful to our community and to healthcare in general. And I want to just briefly talk about them. I'm going to make sure that CAMP Rehoboth has my slides, so if anybody wants them, they can reach out to them, and I'm happy to share them. Each year, the Centers for Medicare and Medicaid provides what they call an annual rule, which governs exchanges and employee-sponsored plans. And basically, it outlines a number of requirements. One of those requirements is related to the use of drug manufacturer coupons. And I know that many of us use a drug manufacturer coupon when we go to the pharmacy to pick up our medication. That gives us a discount on our copay or co-insurance. Sometimes we can get the service for free. The 2021 rule that will go into effect in January has an accumulator adjusted program built into it. And what this basically allows health insurance providers to not count that copay assistance card that you use at the counter to get your medications, having it count toward your deductible or your out-of-pocket maximums for the year, which is very, very problematic. So just quickly, what happens, the drug manufacturer issues that coupon, which you clip or you get from the manufacturer. You use that as cash, basically, at the pharmacy. The pharmacy submits the claims data to your health plan. They know that you paid with a cost-sharing coupon. And what will happen is they will have the option on whether they count the value of that coupon or exclude it, which really leads us to a point at the end of the year or when the coupons run out that individuals will be again stuck with high deductibles, high copays, out-of-pocket costs on their medications. And this is something that we really need to ensure that new healthcare laws in the future protect and exclude accumulator adjusted programs. Ultimately, we want to make sure we reduce the out-of-pocket costs that patients have to pay for medications as they move forward. There's been a number of bills that have been proposed in the House to help correct this. None of them have moved forward at this point. And of course, the Senate has not made any movement on this at all at this point. We've done, over the summer, we've done a number of campaigns that will continue into the fall, making sure our copays count as we move forward. Another issue that we're paying attention to, and this is an unusual way for an administration to implement a rule on private plans or marketplace plans. Medicaid, which typically serves low-income Americans, provides health insurance, has a notice of proposed rulemaking that came out from CMS, And this rulemaking had a number of areas that they covered. I'm just going to cover two, which are important to us. That accumulator adjustment program in best price language. It is very unusual that a public option such as Medicaid would have language in it that would impact private insurance. However, the adjusted programs and best price programs, the manufacturer must ensure, according to this rule, must ensure that the whole value of the coupon is going to the patient in all cases and not to the health plan. And if the manufacturer cannot ensure that 100% of the value is going to the patient, then they must take that price, that cost savings out of the value for what a state is paying for the drug in Medicaid. What is this going to do basically? Well, first of all, the drug manufacturers and the patient has the relationship with the health plan. The drug manufacturer and the health plan have no relationship. So the drug manufacturer would not be able to determine if any of the cost savings went to the health plan and not to the patient in a particular situation. This is ultimately going to cause a lot of these copay assistance programs to expire because manufacturers are not going to want to pass along the cost savings to Medicaid, the state, versus, and it increases what the manufacturers will ultimately have to reimburse to the state for particular medications. This piece of legislation also has some information related to line extensions. And this is really deep, but basically what a line extension is it's a way for manufacturers to prevent their drugs from going generic. And in the past, this has been used inappropriately, where they change the form, the color, the shape, what's printed on the medication, and they say that's a new drug. Well, there was definitions on what was considered a new drug that went into effect under ACA, and this new definition ultimately relates back and it impacts whether a manufacturer makes an extended release, a new dosage, strength, provides new indications, combines two medications. I know there's a lot of medications out there that are combination therapies. It requires them to be penalized for doing any of these items, which could ultimately make adherence to medication better or treatment better for the patient. And it really hinders innovative new products coming to market for a variety of chronic conditions, including HIV, cancer, mental health, COVID-19. And it really disincentivizes or companies from doing research or investment in research for vulnerable patients. Most favored nations, if you're in the DC TV market at all, you will see ads on TV about this all the time right now. This is a huge change for our country. The federal government implemented a new program called Most Favored Nations. And what this basically does is it sets the price based on the lowest price of medication based in 15 countries. So we look at foreign countries to determine what we are willing to pay for a particular drug. And this is basically impacting Medicare Parts B and D. It went into effect on January 27th. Happy Thanksgiving. And it's rolling out over the next year in this place. What basically happens with this is it imports a lot of quality indicators that other countries have placed on certain health conditions. So it's basically asking at times, are you worth is your health worth the investment of paying for a high price medication? This also reduces investment of research and development, restricts access to medication, all American jobs, and diverts resources away from life-saving treatment. There's also a number of importation rules that are going into effect that allows for importation of drugs that were originally manufactured in the United States and then exported for international sale. As we all are maybe aware, the US is really the gold standard for pharmaceutical manufacturing. And it is really important that we maintain a custody of the medication, that we know where, are able to track how the medication moves through the system and who handles it. One of the limitations of importation is not knowing what, in fact, where that medication has been, and can lead to counterfeit or generic drugs from entering our country. We also need to pay close attention to section 1157 of the ACA, which provides non-discrimination provisions of the ACA, which includes discrimination, as you see here, based on race, color, national origin, sex, age, and disability. In the Obama administration, this was extended through an executive order to include trans people and LGBT communities, Spanish language translation, interpretation services, really extended to a broad range of healthcare services. The Trump administration this year rolled that back, and this now has a great concerns for protection of gender identity, protection of abortion access, services for people with limited English proficiency, and it no longer covers trans people in the definition, according to the Trump administration. This is going to be something that is going to need to be solidified in legislation as we move forward. And we really hope that the Biden administration moves forward with enhancing the laws related to this. Sorry, I'm just going to work quickly through here so we can wrap up. Some equal protections that we need to really be looking at as we move forward. The Equality Act, which has moved its way through the House at this point and is sitting at the Senate to be voted on. This is why it's so very important for us to vote to participate in voting, because the Senate or the House could hold legislation and not bring it to the floor. So when we talk about, you're hearing all this discussion around Georgia right now and who will control the Senate. Why? Because those who hold the majority are the chairs of the committees which can advance legislation. The Equality Act would actually amend the Civil Rights Act to include sexual orientation and gender identity protections. And that would affect areas that you see there on the bottom of your screen, from employment to credit to public education and accommodations. There are some transgender protections, which I know we have a person going to speak later on this, but under the Trump administration, there has been almost a total ban on military service for transgender people. There was also regulations that were put in place that basically indicated that if you are in a homeless shelter or a HUD housing, a homeless shelter, I'm sorry, you would only be admitted by biological sex rather than gender identity. And it also, some of the acts of the Trump administration has also removed gender identity and sex stereotyping from the anti-discrimination protections of healthcare, which means that individuals could, in fact, be discriminated against outright because they are not covered under the protections. And finally, under religious freedoms, often clash with anti-discrimination work. The had the opportunity to work on religious exemptions in healthcare. They decided not to do so, and that has impacted individuals being able to decide not to care for people, not to allow adoptions to move forward based on people objecting based on a religious exemption to the law. And ultimately, the Supreme Court, which has been moved to more conservative measures, have commonly sided with religious institutions in the past session. Other healthcare concerns, recommitting to ending the HIV epidemic. This was a Trump administration program that kind of got sidetracked because of COVID-19, and really wanting to make sure that funding and service prioritization happens within the program. And one of the things that we want to make sure is revised in ending the epidemic is it has been missing aging with HIV issues in its planning and a lot of its service provision. And we want to make sure that we continue to collect, healthcare providers continue to collect sexual orientation and gender identity data in healthcare and report that. So we have accurate data of outcomes and health concerns that are emerging. Advocacy is all about you. It's about you calling, writing, visiting your legislator, taking the time to do public testimony, telling your story. Your stories are so important on how legislation impacts you. And we commonly ask for you to engage in activities and to tell us your story so we could share those with legislators. And ultimately, if you're not registered to vote, vote. We must execute our right to vote, and we must demand legislative actions to protect access, promote equality, and improve healthcare. An executive order is not enough. We must have it written in the law. Thank you so much.
Thank you, Michael. Really interesting. I think that really reinforces how small that our worlds have become with COVID, because I literally have stopped thinking about what's going on everywhere else in this country. So
Yep.
Thank you for that perspective, and we'll get back to you later with some questions. Thank you very much. Okay, so next we have Dr. Kameryn Lee. She's fellowship trained minimally invasive gynecologic surgeon in Maryland. After receiving her undergraduate degree in chemical engineering at the Massachusetts Institute of Technology, Dr. Lee attended medical school at the University of North Carolina School of Medicine. During her tenure in Chapel Hill, she also received a Master of Science degree in Public Health from the University of North Carolina Gilling School of Global Public Health. Upon graduation from medical school, Dr. Lee completed an internship in general surgery at Vanderbilt University Medical Center and residency in obstetrics and gynecology at Nashville General Hospital. Her subspecialty training in minimally invasive gynecologic surgery, robotic surgery, and gynecological endoscopy was completed at MedStar Washington Hospital Center in the District of Columbia. Since fellowship training, Dr. Lee's practice has focused on advanced laparoscopic surgery, hysteroscopic surgery, and transgender medicine. For the past 12 years, she has treated patients with pelvic pain, abdominal bleeding, endometriosis, and uterine fibroids using advanced, minimally invasive approaches and techniques. Dr. Lee is one of the inaugural clinicians for Folks Healthcare, a novel and newly established telemedicine company specializing in trans and queer healthcare. Dr. Lee.
Thank you so much, Janet. That was a lengthy and complicated bio, so I'm going to make it a little bit more simple. I'm Kameryn, assigned male at birth. My pronouns are she, her, and hers. I'm from North Carolina. I live in Ocean City and have been living here for the past 4 years. I'm a gynecologist and surgeon. I've been doing that for 16 years. But I'm about to start a new trans health endeavor that I'll tell you more about in just a little bit. For the past 4 years, trans folks have had a difficult time with regard to the current administration, and things in terms of healthcare really haven't gotten a lot better for us. In 2015, the National Transgender Survey said that 1 out of 3 trans people had a negative experience at a doctor's office, and 1 out of 4 don't even want to get any medical care at all for fear of stigma and being discriminated against. So I wanted to go through a list of 10 key health concerns for transgender people that we should really think about and focus on so that we don't miss the overall big picture. The first thing is access to care. Trans folks should be able to find a provider who understands trans health issues. Most of you who are watching are in the local area, and in trying to find those providers is difficult. I've been here 4 years, and it took me about a year to find medical providers, therapists, hormone prescribers, people who knew and understood me. And I understand the system, and it still was difficult for me. So there's some people in the area who do understand, and hopefully on the CAMP Rehoboth website, it'll be updated to where those providers in the area who are competent can be listed so that you can go to the website and find them more easily. But access to care is the most important thing. In just a few minutes, I'll tell you a little bit more about what I'm going to be doing starting in January to make access a little bit more easy. The second key concern is hormone therapy. Hormones should be prescribed by somebody who knows what they're doing in terms of, what to prescribe us, and hormones should never be used on the black market. During the past few months during the pandemic, black market hormone use has really increased, and that's a key concern. There are legal and easier ways to get hormones, and again, I'll mention that in just a few minutes. Issue number 3 is cancer. Trans folks have higher incidences of a lot of cancers, mainly because of not getting screened in advance to be able to find precursors to prevent those cancers. It's important to remember, trans folks, that you all who have a uterus, cervix, and ovaries can still get cancer. Trans folks who still have a prostate can get prostate cancer. So We have to keep those things in mind, but again, it's difficult when you can't find providers who understand us, and I understand that very well. Issue number 4, injectable silicone. I don't know how big of an issue that is in this area. I haven't heard much about it. Usually in the bigger cities, that's an issue, and trans people in general, especially trans women, have to be counseled about the risk of injecting silicone. You can get horrible infections and be disfigured permanently, and can die from just wanting a better figure. Issue number 5 is huge: substance abuse. Trans folks should be screened for substance abuse and get appropriate education and risk-based counseling. That is not happening as often as it needs to be, and for the past few months during the pandemic, substance use among trans folks has increased as well. Issue number 6, depression and anxiety. Our next presenter, Guilford Hurst, is a mental health practitioner, and he may be able to speak a little bit more to this, but trans people should be screened for signs and symptoms of depression. Those rates among us are higher than in the general population, and services need to be found and used as needed. Issue number 7, sexually transmitted diseases. Trans folks who are sexually active need to be routinely screened for STDs. Again, that's difficult if you can't find providers who are willing to do so. So again, I'm speaking to you all at CAMP Rehoboth. Update your website to help us find providers in the area who are competent and can help us get what we need here in the area. Issue number 8, alcohol abuse. We should be screened for alcohol abuse. Studies show that trans folks have a higher rate of alcohol abuse and dependence. Any alcohol use can be a problem for trans folks who have an alcohol-related disorder, so we need better screening and care for that. Issue number 9, smoking, tobacco use. We smoke more than the general population, and we need to be better screened for tobacco use and abuse and be counseled on the risk. All of us understand the dangers of smoking, but that doesn't mean that all of us are committed to trying to stop. And it helps to have providers who can help us to do that. And issue number 10 is heart disease. Trans folks are usually or often at higher risk for heart disease because of hormone use, smoking, obesity. We should have our blood pressure checked regularly, cholesterol checked regularly, and we should learn about the signs and symptoms of heart disease and stroke. So a lot of the concerns that I'm talking about are concerns that apply to the general population, but seem to be and are magnified in our population, and so we need some help. I'm going to share my screen with you in just a second. In January, I'll be starting an endeavor with a brand new startup telemedicine company called Folx Health, F-O-L-X. It's a startup company that has started up just this year, at the end of this year, that's dedicated to providing care for queer and trans folks, providing hormone therapy, PrEP, meds for erectile dysfunction, treatment for STDs, and this can be done from the comfort of your own home. Everybody has one of these. It's all done via telemedicine, and I'm going to play a couple of videos that the marketing team has put together for folks, just to give you a little flavor of of what we're aiming to do. So bear with me. I'm Zoom illiterate, so bear with me for just a minute. All right, video number 1.
I'm feeling wild, child, driving with a blindfold. Don't need a hand to hold. Don't need a hand to hold. I'm feeling wild, child, driving with a blindfold. Don't need a hand to hold. Don't need a hand to
You know, these videos are really meant to show how affirming folks is going to be for trans folks. Here's a couple of videos of community people, community folks who were willing to talk about their experiences on camera.
Queer love is so radical and so amazing and so important, you know, and I just think visualizing and having that representation and just putting it out there, it's just a radical form, or not even radical, it's just we're here, we've always been here, and we're always going to be here. So the systems need to be there for us as well.
I've learned to be confident and comfortable in who I am. For a long time, I walked with, you know, my head down, hunched over, and now I'm very much proud of who I am. And so I think my chest is my favorite part.
Our skin and our bodies are able to tell our stories that we navigate in this world, but also like our resiliency.
No one has my body, no one has my shape, no one has my imperfections.
My favorite part of my body, I want to say probably like from like my abdomen up, like, you know, my tummy, my chest, like all that. I just feel like very empowered, just very like presenting that and just kind of like putting that out there. I don't know.
Let's see, there are a couple more.
Purposely miss doctor's appointments because it would just take me so long to get ready to feel like I'm passable enough to like move in the world, in the city. I had a problem with consistently having my hormones be given to me at the right time, and I feel like it kind of messed with me mentally, emotionally, physically. I feel like folks is kind of like the queer fairy godmother of like the healthcare business. First starting off in your transition, you probably feel like a sense of like self-consciousness and anxiety, like when you're going out in public and trying to present as like your true self. So I think it's really awesome that they have a way to get medication to you without having to deal with the heteros.
And there's one more from Jaden.
My body's a work of art because I'm Black and alive, which is an act of resistance considering the world that we live in. Being authentic to myself, the surgeries I chose to have, the way I chose to be on hormones was really a love letter to myself. And to make that choice every single day is phenomenal. So I'm definitely living and breathing art every single day. Queer folks and trans folks find ways to do accountability that centers love. We're committed to our healing. We are fly. We are joyful. We have the best style because we exist in a world that has constantly been trying to kill us. we continue to exist vibrantly. Queer and trans people just existing and choosing ourselves every day is like one of the most revolutionary things we can do.
Amen. So there are better ways to for us trans folks to get what we need, and if you can't find it where you are, folks is willing to step in and help. So maybe CAMP Rehoboth will be able to add folks' health to their website, and trans and queer folks are welcome to check it out and understand how we work and get some of the treatment you need. All righty, Janet, that's it for me.
Thanks, Kameryn. That was pretty amazing marketing stuff, I gotta tell you. Okay, so our final presenter tonight is Guilford Hurst. And Gil and I have probably been on a personal crusade for the last 10 or 12 years to get services to people who really need them. So I have had the privilege of working with him. So happy he's going to present tonight. He's a psychiatric nurse practitioner, and he treats a really complicated group of people. So anyway, Gil, go ahead. Gil?
I'm here.
Okay.
Here we go. Sorry about that. Thank you very much. I'm going to have a pretty abbreviated discussion this evening because my two esteemed presenters before me covered a lot of the space that I was going to be taking on anyway. During the COVID-19 crisis, the need for treatment has exponentially increased. A lot of times we find ourselves triaging people who have lost access to their care, and we will end up picking up the pieces where they have lost access from. More often than not, LGBTQ people coming to us for treatment will be identified as having traumatic experiences from previous providers. And it's important to offer safe space and ready access to treatment so they don't relapse. Because frankly, if they move to a higher level of care, that may in itself may be traumatic. And as Kameryn stated, it's important for people to be in a safe space where they do not feel like they're being judged or experience bias before they even get back to your office. It's important for stakeholders to identify themselves in the community. I know that SALs on several occasions send out requests for people to identify themselves as being LGBTQ friendly and having bias-free care. And I do believe that this is going to start the conversation, having that more of a comprehensive list, as well as a more integrated group of people. I am going to probably end at this point so I can turn over for questions. And thank you very much. That's it.
Thanks, Gil. Okay,
Thank you.
so yeah, thank you, everybody. Really interesting. It is. Nikki put a comment up there about Dr. Lee's presentation, absolutely amazing. So yeah, so there are some questions here. Kameryn, I think these are for you. The services that you talked about with folks, are they available to youth?
Not yet, because folks as a startup, we are starting with people who are 18 and older. We kind of have to start there to kind of establish a base first before figuring out how to take care of those who are younger. But that will probably come in the future, but not just yet.
And what about insurance? Or, are they going to have the providers panel for the different insurance companies, or are people going to be expected to pay cash?
The whole idea behind folks is to really get away from the tyranny of medicine. It's insurance companies and you know, those establishments that kind of have us, you know, where we are now. So so traditional insurance plans are not being integrated into folks, but it also won't be prohibitively expensive for people either. So we have to make sure that the people who need care can get it. So for the time being, we're avoiding those companies because they haven't served us very well, and we think that we can do better without them. We can provide our own medications through our own pharmacy vendors. You know, we can teach self-injections with videos just like this. You know, so so our goal is to you know, make it for us by us. You know, without the you know, Big Brother watching.
Is there going to be a behavioral health component to folks also?
Yes, there will be. That will be built as well. For the time being, we're really gathering names of providers who are interested and competent and wanting to fill in and help. But eventually, the folks staff will include behavioral health providers as well. But for now, it's starting off with about 6 or 7 medical providers only.
Thank you. Question for Michael. I'm a Medicare recipient. So this is really my question. I had no idea that this most favored nation thing even existed. Can you just talk a little bit more about that?
Sure. It is, well, speaking of that, today is the last day for Medicare re-enrollment for your Advantage plans. So keep that in mind. If you've not re-enrolled, please do so today. But most favored nations put into, well, is being touted as a cost savings measure. So that our, basically what will happen is CMS will negotiate with insurance companies. Well, they won't negotiate with insurance companies. Basically, they'll go to these other countries and they will look for the lowest price for the medication and whatever that medication is being marketed at and sold to at that country. And they will then basically go back to the manufacturer and say, we are only paying what, you know, my brain totally froze up. What what Germany is paying for the cost of this drug, or another, or the UK will only pay with the UK payers. But we have to remember that these healthcare systems, many of them are single payer systems, and they have built in cost containment measures in their systems in which they determine that they will not necessarily pay for some of these new medications that are on the market. And in fact, the United States offers about 95% of the medications that are on the market today worldwide. We as a country have access to those medications. Whether your insurance company will pay for that is a whole other story. But we want to be sure that it doesn't come down to a quality issue in which that they eventually say, well, you know, that 2 months that you might get out of this medication is something that we don't think is important to have in our system, because we want to make sure that people have not only access to medications, but can make choices. for themselves, which is best for their healthcare. And most favored nations import some of those quality adjusted life years with the cost in the country. So it's really scary. It's almost putting America last.
Really?
Versus America first.
Do you think you could put your website in the chat box, so if people wanted to follow up with you for more information, that would be good? Question for Gil. Can you talk about the need for trauma-informed care and providers being culturally sensitive to minority groups of people?
Yes, ma'am. Trauma-informed care means it's to identify the illnesses, and it's a lot of times you have to be able to identify what PTSD is, and how to do it in a constructive manner, and how to be sensitive during the interview as to not activate said trauma. A lot of times depression and anxiety manifests as a result of significant trauma, and people, lesbian, gay, transgender, queer, always, not always, it's a horrible word, statistically experience much more bias in the community, lack of access to treatment, fear of coming in for treatment. A lot of times by the time they come into treatment for us, they've already experienced such trauma from other providers and from the community that you may not be able to get the entire story out of one session or an initial meeting. And you need to take the time to listen. And it may not all happen in the first meeting, it may take 4 to 5 meetings.
Yes, really complicated piece there. I mean, Kameryn, earlier you had talked about, the need to screen people for all these basic, things that we just take for granted. And it's just, and I've been in healthcare a long time, and I agree with you. When people get folks like us in their offices and they are not comfortable, all of that seems to go out the window. And it's like, do whatever you can to get people in and out and just move them on. And it is just, and this just continues today. I mean,
Yeah, it does. It does.
You need to know who you are,
right,
as you go into treatment.
Good. Well, many more concerns.
I will say
Right.
that also brings up an excellent topic around advocating for yourself in healthcare.
Right.
And demanding, I know it can be challenging, but demanding the type of treatment that you feel, you should be getting from providers
Right.
and community. It's so important that we promote us. This is 2020, 2021 is right here, and we're still having these issues. It's a little crazy.
It seems like we've regressed a bit, actually.
A lot.
A lot.
But the problem with that is, with regard to trans people in particular, I can go into an office and demand all I want, but if the provider has no idea, how to treat me, medically or with respect or use proper pronouns or whatever else, then it's going to turn me away. So
you have to be affirming. You have to be affirming in order to get accepting and affirming in order to give appropriate care.
Absolutely. And that's what's missing, not just in this area, but it's everywhere. It's everywhere.
And you brought up an excellent question around making sure that those providers that people have experience with that are affirming and accepting to the communities, to make sure that they get those providers listed others to know about, that they are affirming and provide competent care. Sorry, Janet.
No, that's okay. Maybe that's the next assessment out of Camp Rehoboth, Sal, is to really put together a solid directory of providers down here who truly are trained and affirming of whoever walks into their office, because we really don't have that information here. It's a limited group I promise, but at least it would be good to have a solid list of who people could confidently go into those offices. And Kameryn and Michael, you provided a great segue for me for our next, we're going to do this again, and the next topic is going to be how to advocate for yourself in terms of getting the healthcare that you need. So I think we're out of questions. Anybody else want to wrap up? Sal, you want to, pull this
Yeah,
thing together?
I want to thank everyone for attending this evening. And as part of the continuing work we're doing, we're starting a health committee, like an advisory board that's going to look at health issues along with programming issues. So I'll put my name in the chat box. For those who are live streaming on Facebook, you can reach out to me if you're interested in sitting on this virtual advisory group, salvatore@camprehoboth.com. I will put it in the chat box right now. And I can really tell you, I know people have said, well, what's BB doing? What are Bay Health doing? And I definitely can tell you there's lots of movement now towards getting more providers that have knowledge and experience working with the LGBTQ plus community. There's a new doctor, Dr. Sarah Matthews, who's just starting out of BB. And she brings with her lots of experience working with our community. Bay Health has a great LGBTQ advisory committee that meets, and they're looking at ways to begin adding LGBTQ health specific services. It's very slow moving, but it is happening. And I'm so glad that Dr. Kameryn was able to tell us about this new endeavor that she's part of. I think that's going to be a great option. And if for anything, COVID has really showed us that there are other options, and we can see clinicians virtually rather than having to go into an actual location. I think that's really going to be important, especially for trans healthcare, at least in Sussex County. Because I know, Dr. Kameryn, you can speak for this, and you did earlier saying it was really hard for me to find clinicians. And I agree with you. I think that's our biggest challenge is education, and then also identifying providers who not only say, yeah, I feel comfortable working with this community, but also who have experience. And that's been our biggest thing. We can have so many providers on our list saying, yeah, I work with the community, or I'm okay working with the community, but do they have training? And the answer to that, unfortunately, is they don't have training. They would like to work with us, but they don't have the training. And that's the really big challenge we're facing. And I think BB is really trying to work on providing some training. And I definitely know Bay Health is beginning to do that. And I think as advocates, we can reach out to them and say, can you move a little quicker, making sure that all of the physicians within your hospital network are being trained.
Thanks, Val. Okay, I think that about wraps it up. Thank you, all of you. It was fun to get together tonight, see your faces, and we look forward to the next go around with this.
Thank you, everyone. We appreciate it. Janet, Dr. Kameryn, Michael, Gil, thank you so much on behalf of CAMP Rehoboth. Have a good evening, everybody, and thanks for joining us. Bye.
Bye, everybody.
Bye-bye.